Hello, dear future nursing officers. Welcome you all to the Master Nursing classes. In the last previous class, we have discussed the most important questions on the endotracheal tube, suction pressures, and some image-based very important questions we have discussed. Some criteria, some guidelines, some true fact, some concept, some questions, everything we have discussed that is much necessary for our upcoming exams. So, in the today's class also, we are going to discuss such a beautiful concept questions that may be a scenario based questions, one line questions, everything that is important for your upcoming exams. So, I am delivering a single shot best class in this particular class. I am going to discuss the everything that is a clinical based, scenario based, and a concept based everything questions. So if any form of the exams you people will face, so you people will not feel it's new to you, right? So everything we will discuss in the today's class. Good evening, very good evening, beta. Welcome once again to the master nursing classes. Fatafat, hit the like button. We will start the today's class. Fatafat, who all are live to the session. Welcome everyone once again to the master nursing classes. Good evening, very good evening. So, as I previously told, if you want to learn completely, means you have to engage in the class completely. Whether it may be a right answer or wrong answer, whatever the question I am asking here, so try to put your answer in the comment box, okay? And please try to don't delete your comment once after you commented, because it will demotivate you, right? Whether it may be a wrong, no problem, I am here to connect, okay? So don't have to fear when your master is here, right? Okay, good evening beta, very good evening, welcome once again to the master nursing classes. Fatafat do hit the like button, we will start the today's class. And who all are watching the master nursing classes first time, hit the subscribe button. It is very much beneficial for your rank, your concept, and it's beneficial also for your knowledge, right? Very good evening, very good evening. We'll start the today's class. Fatafat hit the like button. Yes. Okay, we'll start the today's class without wasting the time with a beautiful motivational quote. Bacho, it's the end of the preparation. Here you have to believe on yourself, and here you have to think big. So if you are not believing on yourself, means aims will not believe on you. When the aims will believe you, then only they will give a placement and job to you. So it's mandatory to believe on yourself. You know everything. You are the knowledgeable person, and you are the competent nursing officer who wants to join the aims. So this kind of the belief system you have to keep in your mind. Everything is possible. Think big, trust yourself, and make it happen. It's highly possible. Nothing is impossible when a positive vibes creates on you, right? So with these positive words, we will start the today's class, and here is the first question in front of you people. Okay, try to respond and give the best answer in the comment box. So this is the question I have taken from the last class, because some students they have mentioned the doubt on this particular concept. Sir, whether there are the two type of the pressure are there in the suction? Yes beta, there are two type of the pressure are there in the suction. One is the wall mounted suction pressure, and one is the portable machine suction pressure. So which one the examiner will ask in the exam? Many times, 1,000 times question asked, and 1,000 times he repeatedly asked the question on the wall mount suction pressure only. So you also have to read this one only and remember this one only. In addition to this one, I will tell the portable also, so remember that one. And in the last class I have told the image based question of the portable and wall mounted section both. So where there is a zigzag of the images are there, so some students got confusion. Again, I want to clear your confusion and start the today's class, and I want the best response from your all side for this particular question which is there in front of you people, right? So let me read the question once again for you people, right? What is the typical suction pressure ranges for a wall mounted suction used in an adult? Yes, we are using the suction to the adult patient. That is the wall mounted suction. So what is the typical pressure you people have to apply here, right? So image I have shown in the last class only, right? Like one board is there, so here the yellow bottle will be there. So yellow bottle everywhere it creates the a negative vacuum. Okay, negative vacuum means a suction pressure, right? So I want the answer in the comment box. Who all are live, everyone please try to insert your answer, right? Very nice, very nice. So almost all you people chosen the option D as a correct answer. So this is the correct answer, bacho. So this is the wall mounted suction pressure. Okay, so this is the wall mounted suction pressure. Very very important, all you people have to know. So last time I have shown the image here, that was the uh, portable, so that's what you people got confusion. So I want to clear you people, this is the wall mounted suction pressure, right? Right, yes. So we'll start the very important golden point chanting. If the examiner is asking the question, the suction pressure in the new units, it's 60 to 80 mm of Hg. And in the last class I have told, if the examiner asking specially mentioning the preterm unit and term unit, your answer will be different. So for the preterm unit, you have to keep the suction pressure. Yes, I have told in the last class. Anyone want to answer a suction pressure in the preterm unit? Fatafat. Already told in the last class. Yes, but very, very good, very good. Okay, that is the 40 to 60 mm of Hg is the suction pressure we have to keep in the preterm unit, and for the term unit is a standard pressure, that is the 60 to 80 mm of Hg is the correct answer. Okay, so when the examiner mentions as children in the question, if he mentions the suction pressure in the children, means the answer will go to the 80 to 100 mm of Hg, right? So this is the standard suction pressure we have to apply to the children's. Okay, so when it comes to the adults, yes, he asked in the question, that is the adults, right? So our answer is suction pressure 100 to 120 mm of Hg. Okay, maximum we can go till 150 mm of Hg. So this is the maximum suction pressure we can go. Okay, not more than 150. So the standard and best is the 100 to 120 mm of Hg. It's very very important. Okay, so again to completely clarify, okay, here is the again one question on the suction pressure on the portable suction is. So try to give answer. What is the typical range of the suction pressure for a portable suction machine in an adults? Okay, so again the same question is asking on the adults, but they have mentioned it's a portable suction pressure. Okay, so the machine I have shown in the last previous class. Okay, like this machine will be there, so two jars will be there here. Okay, so with this the wheels also will be here, and the suction pipe will be there. So we have to attach to the suction catheter, and we will do the suction here. Okay, so this kind of the image I have shown already in the last class, right? Yes. So what is the suction pressure we have to maintain in a portable suction machine to apply suction to the adult patient? Yes, very nice of you all. So your answer is correct. That is the 10 to 15 mm of Hg is the suction pressure we have to apply to the adults. So in the last class, there are zigzag of the our images. So you people got confused. So again, I have brought in point. That is the only reason to bring back these questions here, because a clarity is important before the exams, right? So that is the reason. Okay, so the C answer goes correct here. And let's quickly revise the suction pressure of the portable machine. Okay, this is the portable machine suction pressure to suction the airway, right? So if the examiner asking the question, a suction pressure in the neonates, so it's in 2 to 5 mm of Hg suction pressure in the children's, then 5 to 10 mm of Hg suction pressure in the adults. So that is the 10 to 15 mm of Hg. So the question is very much clear. They have asked on the adults, so our answer is 10 to 15 mm of Hg. So hope the golden point chanting and the concept is clear to you people. Here is the a very, very, very important question. Bachcho, the question last time in the Norcet, they have asked the total three questions on the what we can say the size of the suction catheter. One question which was on the standard size. A two question is belongs to the calculative size. So here I will tell the both up to 7 French of the our what we can say up to 7 of the ET2 which is having the standard suction catheters. After 7 of the ET2 we have to calculate the pressure actual size of the suction catheter. So both I will describe in detail in easy and very perfect manner. So you have to keep this concept in your mind and apply this formula what I am telling here. It will definitely gives you a correct answer and it will definitely gives you a best, better and a very important all India rank number one, right? Yes, you all are made for all India rank number one. That is, you people have to believe. Okay, so just I want to qualify, just I want to get a job. So it will not work in today's competition. You have to say that I am here to get all India rank number one. Okay, it's possible from my students. If you are working hard, okay, if you are truly dedicated on your dreams, definitely it's possible. Always big aim and big for the all India rank. Yes, aim for the all India rank number one. Okay. Yes, the question is very simple. For an adult patient with a endotracheal tube size of 8 mm, which size suction catheter is typically used? Okay. While telling the ET tube size, I have told you people ET tube size is always determined by the ID, that is internal diameter of the ET tube. And that time I have mentioned a specific very golden point. ET tube size is very much important and it is determined by the internal diameter of the ET tube. Why? Because based on the internal diameter of the ET tube, we have to calculate the suctions catheter size. So that is what the ET tube internal diameter is very important. Okay. So let me clear your concept, bacho. Consider this is our endotracheal tube. Okay, so it is having the hole. It's our endotracheal tube. I have inserted this endotracheal tube in the patient. Okay, so on this endotracheal tube, here it is written ID 8.0. It means internal diameter of this endotracheal tube. Tube is the internal diameter, means this inside the diameter of the endotracheal tube is the 8 mm. Okay, so I have to choose a suction catheter which is half of this particular ET tube. So here the ET tube internal diameter we are considering and a suction catheter. This is the suction catheter consider. It's actually not a suction catheter. Just for example purpose I am saying. Consider this is a suction catheter. Here we have to consider the suction catheter external diameter, not internal diameter. Bacho, suction catheter's external diameter will be very important and in ET tube internal diameter will be very important because to suction a ET tube we have to insert this particular suction catheter in the ET tube like this. Okay, so in the rotating manner while removing the ET tube we have to apply the suction pressure. So the suction catheter size should be half of the internal diameter of the ET tube. A very important where you people have studied the Newton's law. Yes, so like this only, like the same only. Here also one law is there. So the law is to calculate the suction catheter size. Consider it is always a 50 percentage or the half of the size of the internal diameter of the ET tube. Okay, so ET tube is a 8 mm means so it should be a 4 mm, but we will not describe this particular suction catheter size in the mm because to determine this one we are using the external diameter. So external diameter means we will say the French. What we can say? We will say the French. Okay, What is the meaning of French? One time examiner asked the question, what is the meaning of French? The French is the outer diameter of the suction catheter, or the outer diameter of the, we can say, any type of the catheter. Wherever the French will come, it's indicating the outer diameter of the catheter. Okay, so this is very, very important, the outer and inner diameter, because it will create some confusion to you people, right? So the concept is very much clear. Now I will tell you one beautiful Benki formula. So that formula you people have to apply to determine the a particular suction size, catheter size in the questions. Okay, so very simple. The question is, for an adult patient with the endotracheal tube of the 8 mm, which size suction catheter is typically used? So option you are getting the 6 French, 8 French, 14 French and the 12 French. So in order to calculate this one, we have two formula. First I will say the one formula. So that is a ET tube size into 2. Okay, so when I will take this formula, I have to choose a, what we can say, once again, so I will clarify. Okay, so first I will calculate this one. I will share it will be very much clear to you people. Okay, so ET tube size into 2, when I will take on, so now the ET tube size is 8 here, then I am multiplying this one with the 2, so it will be coming 16 French. When it will come the 16 French, so this will be not our answer. This is not our answer. I have to take this one step before. Okay, so that is the 14 French. So before next number I have to take. Okay, not forward. Okay, backward next number I have to take here. So that one here our correct answer. When I am using this formula, endotracheal tube into tube size into 2, so I have to choose a before next number, very, very important. So my answer is 16 came here, but I am the correct answer I have to choose in the exam is the 14 French. Okay, so this is the correct answer is 14 French. Sir, this is the one formula. So another formula, which one, sir? Yes, let me tell. Another formula is very, very simple. That is also second formula is ET tube size into 3 divided by 2. So let me calculate this one. ET tube size is, in the given question is the 8 mm. So I am multiplying this with the 3. Then I am making divided by 2. Okay. So now the answer it will come as the 12. Okay. Calculate it. It will come as the 12 French. But when I use this particular formula, I have to choose next number. Okay. So here the answer came 12. So I have to choose the 14 French. Okay. So I have to choose the 14 French. But when you will use this particular formula, ET2 size into 3 divided by 2, you have to choose the next number. So question came here as the answer came here as the 12. So we have to choose the next number. When you are using this particular formula, ET2 size into 2, you have to choose the before number. Here you have to choose the after number. Here the answer came 16. We are choosing the 14. Here answer came at 12. Here we have to choose the next number, that is the 14. So again the answer is same. So for 8 mm internal diameter catheter, we have to use the 14 French suction catheter. So that is the very, very important, right? These are the two formula you people have to consider and apply the answer. Okay, very important. I am telling again, note down. So whichever the formula you are applying, so make sure that if you are applying this one, you have to come back one step before for the this particular formula, and you have to go back, go front one step up forward to the this particular formula. Okay, so don't keep the answer blindly, whichever the answer will come. So remember this last step, forward and backward. It will gives you a correct answer, right? So hope the concept is clear. And as I told just a statement, in general rule, the selection of the suction catheter is that the diameter of the suction catheter should be approximately half of the size of the ET tube. Okay, so why? Because I want to insert the suction catheter inside the ET tube. If both are equal, consider this is the ET tube and this is the suction catheter. If both are equal, means the suction catheter will not go inside. So the suction catheter size should be half of the internal diameter of the ET tube. This is the standard word you people have to remember. Okay, so these are the some standard ET tube size where we have to choose. Okay, where we have to choose this one. So 6 French is the a best suction catheter size for the 2.5 to 3 mm each tube. Okay, so and for the 4 mm of the each tube, 8 French is the best. For the 4.5 to 5 mm, 10 French is the best. For the 6 to 7 mm, 12 French is the best. And for the 7 mm, 14 French is the best. So here it's almost double we are taking. It's double in number only, but when we say this is in French, so it's in half only. Okay, so just it's a saying double in number, but it's a half of the size of the each tube only. Okay, so when you will see practically that will gives you a clear guidance, clear idea to you people, right? So remember, very important this one. Okay, till the 7 mm we are having the standard. So after that we have to calculate. So formula I have told you people. Okay, so here is the color coding. Sir, whether we have to remember all color coding? No, you have to remember three important color codes what I am telling here. Okay, so one is 6. This is used in the neonate. Okay, neonates, when you see the diaper of the neonates, it's always will be light green or the light yellow. So remember, there is the light green is the color coding for the neonate. Okay, very important. Okay, then comes to the 14th suction catheter number, 14. So this one 14 French is a green color, most commonly used in the hospital. Which suction catheter is the 14? So remember the 14th, very important. Most common suction catheter used in the hospital is the 14 French suction catheter, which is green in color. Remember this one only and only. So one more, there is a 16 you have to remember. Okay, with a orange. Okay, 16 suction pressure you have to remember with the orange. Okay, so I'm making a diagram here for your best understanding purpose. This is the orange color flag. Okay, so write a number 16 on this one and remember, very important, the suction catheter number 16 is the orange. Okay, and light green is for the neonate, and gray also we will use. The least one is the gray, that is the 5 French. So best we can use is the 6 French. Okay, very important. So these three people remember. Okay, if possible remember number 12 also, that is the white color. Otherwise leave it. Okay, at least three: orange, green, and the light green. You people have to must remember this one. Okay, because the 14 is the most common, used in the hospital and used for the adults, and light green is the best used in the very important in the neonate. Okay, so hope the concept is very much clear to you people. And here is the next question. Yes, just a second please. Right, so the question is very simple again, and it's a very important question, procedure based question. Yes, when performing the suction, when should the suction pressure should be applied to the catheter? Okay, you are performing the suction in a patient with the endotracheal tube. Now, during the procedure of the suction, when we have to actually apply the suction pressure. Okay, so this is the UT tube you consider, and you are inserting like this. While inserting, you will apply the pressure. No, while inserting only you will apply means. So till the suction catheter goes inside, till that the hypoxia will happens, right? Because the suction means it will sucking means it will suck the air also, it will suck the oxygen also from the lung and alveoli, so lungs may get collapsed. So don't apply the suction pressure while inserting the tube. Okay, so when we have to apply the suction catheter, so we have to when we have to apply the suction pressure means while removing the suction catheter, so we have to rotate it. Okay, we have to rotate it, and while removing we have to apply the suction catheter. So suction duration should be always less than 10 second. Okay, what is the duration of the suction? Yes, always less than 10 second will be our suction duration. Very important. Okay, so when we have to apply the suction pressure, so when we have to apply suction pressure means our answer is yes. Few of you already chosen the correct answer. Very nice. I'm very proud of you all. Okay, yes, during the withdrawal of the catheter. Okay, only while during the withdrawal of the catheter we have to apply the suction pressure. Very, very important. Don't apply suction pressure while inserting the suction catheter. While removing, we have to rotate it and we have to apply the suction pressure, because it reduces the hypoxia and it reduces the duration of the suction, and it will removes the all secretions also, and most importantly, so it will not damages the our what we can say trachea also. Okay, so very, very important. Then the next point is, in the last question, means in the last session I told the ET tube, the ET tube where we are inserting, this is the vocal cord and this is the trachea, this is the carina, consider. Okay, okay, this is the trachea, this is the vocal cord, and this particular part where the right and left bronchus divides, so this is what we call as the carina, right? I have told in the last class. And when we insert the ET tube, I told the ET tube should be 5 centimeter. Endotracheal tube I am talking about, Miss future nursing officer, right? So here it should be 5 centimeter above the carina and 2 centimeter below the vocal cord, I told. And one student, he commented that, sir, it's in 2 centimeter above the carina. No, bacha. So the problem is, you have studied the section, okay, where you have seen that it should be applied 2 centimeter above the carina. Okay, so let me clarify. This is the correct concept what I told. Okay, where you got people got confusion is, this is the trachea and this is the carina. Okay, so while inserting the suction catheter, we have to insert till this particular carina. Okay, so means we have to insert the suction catheter until the resistance comes and until the patient comes. Yes, repeat with me. Till what depth we have to insert the suction catheter? So we have to insert the suction catheter till the resistance will comes to the suction catheter and till it reaches the carina and till the patient will cough. Once the patient will cough or once the resistance created, we have to take it back. We have to take it back 2 centimeter. Okay, so now the suction catheter I have inserted till the carina. Okay, but the suction pressure I have not applied till. Okay, so this is the why the reason we have to apply the suction catheter while removing the suction catheter. Okay, so you have to apply the suction pressure while removing the suction catheter. Okay, so very, very important. Okay, so now the resistance came and I have pulled back the particular suction catheter back and it is now 2 centimeter above the our carina. So now I will apply the pressure. Okay, so when we have to apply the pressure, yes, we have to insert it till the resistance come and 2 centimeter we have to take back and apply the pressure. Okay, if by mistakenly the your suction pressure attached here and you have applied the what we can say the suction pressure you have applied means, so it will irritate the carina. Okay, here the our 10th cranial nerve is there, that is the vagal nerve. Okay, this vagal nerve will get stimulated and it will activate the parasympathetic nervous system. So activation of the parasympathetic nervous system will cause the bradycardia. It will cause the bradycardia. Most important, why the bradycardia happens during the suction means because of the activation of the vagal nerve. Okay, because of the stimulation to the vagal nerve, yes, it happens the bradycardia, right? So that is the reason we have to insert the suction catheter till the resistance come and we have to take back 2 centimeter and we have to apply the suction pressure. That is the very, very important concept you have to know. Okay, so that is the, I think it's very much clear. Okay, so this first one for the endotracheal tube and this one for the suction catheter. Hope it's clear to everyone. So this is the speciality, comparison and clarify and study and give the best shot and get the better result. Okay, so that is the that is the best method of learning, right? Yes, so hope it's completely clear to you people. And the correct answer, when we have to apply the suction means while removing, and few more points I have told you people why bradycardia happens because of the vagal nerve stimulation when the suction will apply to the carina. Okay, so till what depth we have to insert till the resistance come or till the patient comes, Till that we have to insert the suction catheter. Okay. So along with that, so we have to, after resistance coming, we have to take back the 2 centimeter back, then apply the suction pressure. So these are the very much important golden points I have told to you people on the suction catheter. Okay. So here is the next very important question in front of you people. So do read the question completely till the end and give the best answer. Yes, I'm waiting for your answer. It's a very important question. The difference between the open suction and closed suction. What is the key difference between the, or key advantage between the open and open suction as compared to the closed suction? Okay, so the advantage of the open suction we have to say as compared to the closed suction. Option A, increased risk of the hypoxia and airway trauma. Increased risk of the hypoxia is there in the our open suction. Why? I will tell you this one. Okay, don't worry. So why means, look at this image. Here is the open suction. Open suction we are doing to the patient on the endotracheal tube. Okay, here we are doing the open suction, means we have to remove the oxygen source here. Means we have to disconnect the patient from the ventilator, then we have to do the suction. So that is what we call as the open suction. If I have disconnected the patient from the ventilator, means there is the highest chance of the hypoxia is there in the open section. So this is the disadvantage, not an advantage. Okay, but examiner asking the question, what is the key disadvantage, right? What is the key disadvantage? So disadvantage we have to describe here, right? So what is the key disadvantage of the open section? Means it increases the risk of the hypoxia. Yes, it increases the risk of the hypoxia, and it also increases the risk of the airway trauma also. Yes, yes. So option B, longer duration of the procedure. No, it will be based on the, depend on the competency of the nursing officer and the practice of the nursing officer and the experience of the nursing officer. So this is the not depends on the open and closed one. So I'm eliminating option B. Then comes to the option C. Option C is greater risk of the infection due to the need to disconnect from the ventilator. Yes. So this is also a very important. Greatest risk of the infection is there in the open section as compared to the closed section, due to we are disconnecting the patient continuously and repeatedly before suctioning from the ventilator. Okay. So that is also our correct answer. Two options are going here as a correct answer, right? So then comes to the option D, more complex perform. Yes, it's depend on the, again, based on the experience of the nursing officer. Okay, so here very importantly, you people have to choose a single best answer. Which one? Means, yes, that is, question is related to the suctioning, means we have to choose the best answer as a option A. Even the both answer is correct, because it is the highest chance of the hypoxia there in the open suctioning, because we have to disconnect the patient from the mechanical ventilator, right? And greater risk of the infection is there. Both options are correct here. Okay, but examiner will throwing the question like this, means you have to choose the one single best answer. There is the option A as a correct answer, right? So this is how the examiner asked the question in the previous year question paper. Okay, so that's what. So it's an important to choose the single best answer. So I'm telling the correct answer. That is the option A goes the correct answer here, right? So hope it's clear. Just a second, please. Yes. So it's clear, I think. And it's very important to study the difference between the both open section and closed section. This is the open section and this is the closed section. So a closed section image I have shown already in the last class. Okay. Just I am mentioning the important differences. Here we have to disconnect the patient from the ventilator. Okay. Disconnect from O2 source. Here no need to disconnect. From one end the ventilator we have connected, and from the another port we are doing the suctioning. So no need to disconnect from O2 source. From O2 source. Okay. We are disconnecting here, means highest risk of the hypoxia is there. Yes, the hypoxia will develop here. Yes. and there is highest risk of the infection also there. But as an acute condition, here we have to choose the best one as the hypoxia, because it happens immediately and infections will not happen immediately, right? So the hypoxia is the best preferred answer I have told in the last question, right? So here I told no need to disconnect from the O2 source. Okay, the advantage is there is less chance of the hypoxia and there is less chance of the infection. Now comes to the question when we have to change the suction tube. Okay, so every time you are taking the suction tube, you have to take it fresh. Okay, so one section, how many times you can use? So one section you are using means just without any delay in the procedure, you are continuously you can use that one for the 3 times. Okay, so insert inside, okay, rotate and pull it back. One time done, again we have to insert after few seconds. Okay, again secretion we have to clear, then pull it back, again we have to insert, again secretion have to clear and pull it back. So once you used, disconnect the catheter, okay, and discard the catheter. But this particular suction, closed suction catheter, we can use till this one for the 72 hours. Same catheter we can use. So this open one we have to discard every time and we have to take it as a fresh every time. Okay, so one thing we have to notice here, this open suction catheter, so this will be the suction catheter like this. On this one the polythene bag will be there. Okay, so the plastic bag will be there. So everything, every time while handling the suction catheter, don't have to wear the sterile gloves, you can wear the clean gloves also. Okay, so to do the closed suctioning, just clean gloves also. Okay, so this is the clean procedure. But when you have to use the suction open catheter, every time you are handling the directly you are holding the suction catheter in your hand, means always you have to use the sterile gloves. Okay, always you have to use the sterile gloves, very very important. And open suction is a sterile procedure and closed suction is a clean procedure. So this is what the major difference all people have to know. Okay, it's a very very important bacho, it's a very very important. Hope the concept is clear on the open and closed suctioning, right? So here is the next question and very very important. So identify the image. Already we have discussed this one. Okay, so the image is the tracheostomy tube. Okay, so this is the tracheostomy tube and this is the obturator. Okay, so I will tell the importance of the what is the obturator and what is its important. And this is the outer cannula and this is the flanges. Okay, here we have to tie the straps. Okay, so like this the straps will come, so that one we have to tie there, right? So here this is the outer cannula I told, and this is the cuff, and this is the pilot balloon. And pilot balloon having again the one way spring loaded valve. Okay, so very very importantly, and this is the decannulation plug. So this is the inner cannula. This inner cannula will be inside the our tracheostomy tube. Okay, this is the inner cannula adapter. Okay, again this will be standard size of the 15 mm and it will connect to the standard size of the 22 mm of the our ventilator circuit. Okay, so before removing the this inner cannula from the outer catheter, outer cannula, so we have to rotate the this decannulation plank. Okay, then only the this particular inner cannula will come out. Don't forcefully pull the inner cannula. Okay, so many freshers who went for the tracheostomy care, they will try to forcefully pull the inner cannula from the tracheostomy tube. That time both inner cannula and the outer cannula will comes out. Okay, before coming pulling the inner cannula, we have to rotate the this decannulation plug. Okay, so this decannulation plug is rotated means it will opens the lock and we can easily remove out the inner cannula. Okay, so this is the obturator. Now tell me the questions on the obturator. So what is the importance of this obturator? This obturator is very important. Okay, which is having the blunt what we can say tip, where it's help for the easy insertion of the tracheostomy tube. One is the help for the easy insertion of the tracheostomy tube. Another one very very important means if the tracheostomy tube is accidentally dislodged, means the tracheostomy tube accidentally came out. Okay, so that is what we call as in the yes accidental decannulation of the tracheostomy tube. Sir, what is decannulation, sir? Decannulation, as I told in the ET tube while telling the ET tube only, Intubation is the insertion of the ET tube. Extubation is the removal of the ET tube. But when it comes to the tracheostomy tube, while removing the tracheostomy tube, we don't call that one as the extubation. So removal of the tracheostomy tube is called as the decannulation. Okay, what you call this? That is as the decannulation. Okay, means this ET tube is came out. Okay, like that, right? So hope it's clear. If the patient is accidentally decannulated the tracheostomy tube, means the tracheostomy tube came out. So that time we have to use this obturator and immediately need to insert the tracheostomy tube. Okay, so what is the best response when the patient will remove the tracheostomy tube accidentally out? Means immediately reinsert the tracheostomy tube is the priority nursing intervention. What is the priority nursing intervention? Yes, if the patient accidentally removes the tracheostomy tube, immediately reinsert. Okay, in the option they will give close the hole with the fingers and hold it like this. Bacho, already patient upper airway is obstructed, then only we have created the tracheostomy tube here, right? So the tracheostomy tube also came out, the upper airway is obstructed, then you are choosing the option that close the hole, means from where the air will go to the lungs. No, never ever close the hole of the patient which is created here if the accidentally tube comes out. Okay, so always keep the hole open only and immediately need to reinsert the tracheostomy tube. So to reinsert immediately we need this obturator. So remember, if the patient on the tracheostomy, means always keep the obturator at the bedside. Okay, so that is the very important point I want to tell you people by making the scenario here. Okay, so always keep it at the bedside, very important. And remember, whenever the patient is on the tracheostomy, so two tracheostomy tube we have to keep at the bedside. Why sir? Why sir means, so one is if patient accidentally removes that one, okay, so we have to reinsert the new tracheostomy tube if the old one is contaminated. Okay, so if it came out, means it will fall on the ground. So once it's fall on the ground, means we can't use the same. So that's what immediately we have to open the new one and we have to insert the new tracheostomy. Sir, the old one is we have inserted, that is a big size, now it's not going inside because of this some stenosis of the this tracheostomy hole. So that is the what reason I told the two tracheostomy tube we have to keep at the bedside. One is small size and one is same size. Okay, first try to insert the same size. If it's not going, use the small size. Okay, so if the patient is accidentally remove the catheter. Okay, so this is what the importance of the obturator, and we have to keep it bedside and we have to keep the two tracheostomy tube bedside. Okay, one is small size, one is same size. So that is the very important, right? So this is the flange one. So for this flange, so we have to strap the our tracheostomy, what you can say, the strap. Okay, so that will comes here, so it will fit here like this and we will take it back and we will tie here back. Okay, so when we have to change that one, so we have to change that one when it will get contaminated. So with the sputum or with the any kind of the blood something, if the strap is contaminated, then we have to change that one. How we have to change that one, sir? That is the very important to keep the tracheostomy tube in place, right? So you are removing that one, means tracheostomy may comes out. If the patient coughs, the tracheostomy will comes out, right? So that is the reason where we have to tie the new strap first, then remove the old one. Okay, so first tie the new one, then remove the old one. That is the very important. Okay, so it's some clinical based questions they can throw in front of you people. Okay, while changing the strap of the tracheostomy tube, so what we have to do? Yes, we have to remove the we have to tie the new one first, then we have to remove the old one. Okay, in order to prevent the decannulation of the tracheostomy tube. It's very important, right? So before removing the inner cannula, we have to rotate the plug of the decannulation, then we have to remove our inner cannula. Okay, the question will come, so inner cannula should be cleaned with which solution? Okay, the controversy question, many times the examiner asked, so always answer goes to the hydrogen peroxide, best answer. Okay, with normal saline. Okay, if only one answer you want to push, put the hydrogen peroxide used for the cleaning the inner cannula. Okay, so if this inner cannula is not an answer, hydrogen peroxide is not the option. So NS will be the 0.9 percentage. Normal saline will be the best answer. If both in answer, okay, that is the what we use in our clinical practice. Hydrogen peroxide plus NS we will mix and we will clean the inner canal. Okay, so this is the best answer, right? So hydrogen peroxide plus NS we should mix and we have to clean the inner cannula. So that is the very important. Okay, so this one also the examiner can throw in front of you people. Okay, so this is what the golden point chanting on the tracheostomy tube, its function and its particular parts and important question on the individual parts. Okay, so again the cuff as usual same like a 82. Okay, so the cup pressure is, yes, when it will comes to the mm of Hg, it's in 20 to 25 mm of Hg. Okay, when it will comes to the centimeter of H2O, that is the 25 to 30 centimeter of H2O. Okay, very important. So this is the cup pressure. So what we can use for inflating the cup? Yes, again the air. So amount of the air to inflate the cup, that is the 10 cc or the 10 ml of the air we can use. And when we have to deflate the cuff, means every shift or every 8th hourly we have to deflate the cuff, and whenever the patient want to talk, then you have to deflate the cuff. Okay, so not initially, don't decannulate, sorry, don't deflate this cuff in the initially. It's a very important. And first 24 hours. Okay, so here we have to insert the dressing also around the tracheostomy site. So first 24 hours don't change the dressing. Okay, whether it may be swollen or whether it may be bloody, it's an over bloody means heavy bleeding is there, then we have to inform the doctor. Okay, slight normal blood. Okay, so slight normal bleeding will be expected. Okay, if it's more than normal, so we have to inform the healthcare provider. Okay, and don't change the dressing for first 24 hours. Okay, for first 24 hours after tracheostomy, don't change the dressing. So after that, and every 8th hourly, sorry, every 24 hourly we have to change the dressing. Okay, so when we have to change the dressing, every 24 hourly we have to change the dressing of the tracheostomy tube. Okay, so always remember the gauze used is the 4:4 size. Okay, and it will be like this. We have to cut and we have to insert the particular gauze bandage here. Okay, below the this particular flanges. Okay, so it will be very important. And to clean the tracheostomy site. Okay, this is the tracheostomy site where I have created the tracheostomy. To clean this one, which solution is used? Yes, that is the 0.9 percentage normal saline. Okay, so that is 0.9 percentage of the normal saline is used to clean the stoma site. Okay, this is the opening site. So to clean this one, I am using the 0.9 percentage of the normal saline. These are the very important questions the examiner can throw in front of you people. Okay, so remember, be active and focused over the question what the examiner wants to ask you people, and try to give the best response to the every question based on the what actually examiner wants to ask to you people, right? Okay, so here is the next question. Hope everything on the tracheostomy image and its particular related questions are clear. Okay, so here is the next question in front of you people. Do read the question carefully, perfectly, and try to give the best answer. Okay, which of the following is contraindication to perform tracheostomy? To perform tracheostomy, which of the following is the contraindicated? The examiner is asking here. So, what is your best answer? Option A, acute upper airway obstruction. Yes, tracheostomy is preferred in the acute upper airway obstruction. When we have to go for the tracheostomy, if this upper airway is obstructed, then we have to go for the lower airway opening, that is the tracheostomy. If this one is not obstructed, I want to use the airway, means I would have used the ET tube also. Okay, from mouth I can insert and it will go into the trachea. But this one is obstructed, then only I am going for the tracheostomy tube. So this is the indication. It's a not contraindication. It's an indication of the doing the tracheostomy opening. Okay, so it's a not contraindication. But examiner asking here is the contraindication of the performing the tracheostomy. So option A, it's an indication. That time we have to actually create the tracheostomy. Okay, so then option B is the chronic respiratory failure. Yes, the examiner is asking whether we have to choose it in the chronic respiratory failure. Yes. So for the long term airway management, we have to go for the tracheostomy only. Okay. For short-term airway management, we have the basic airways, and for ET tube also for the short term only. We can't keep the ET tube for the months, 2 months like. Okay, if the patient depended for the long duration on the ventilator, you have to go for the tracheostomy tube. That is the best one. Okay, so chronic respiratory failure, the best one is the tracheostomy tube. Okay, and option B is telling need for the long-term mechanical ventilation. That time also, yes, we have to go for the tracheostomy tube. Okay, so it's preferred if you want to maintain the airway on by ventilator more than 14 days, or we can say more than 2 weeks. So best is the you have to choose the mechanical ventilator airway, that is by the tracheostomy tube. Okay, so you want to keep the patient on ventilator for the more than 14 days or more than 2 weeks. So we have to use the tracheostomy because it's used for the long term. Okay, EG2 will be only for the short duration. You want to keep the patient for the 16 days, 15 days on the ventilator means go for the tracheostomy. Okay, so very important. These questions are asked in the exams till how many days if you want the ventilator means we have to keep the patient on the tracheostomy. Yes, if the ventilator support required more than 14 days, go for the tracheostomy. Okay, so I have repeated 3 times. It's important for you all, right? So I think it's completely clear to everyone. Okay, so the question is asking the contraindication for the performing the tracheostomy. Yes, if any bleeding disorders are there, if any severe coagulopathy is there, then if you are creating a incision here, means it will bleed heavily and patient may go into the hypovolemic shock. So the severe coagulopathy and bleeding disorders are clearly contraindication of the our tracheostomy creation. So the correct answer is option C goes to the correct answer here. Okay. Hope the concept is clear to everyone. Right. So here is the next question. Here is the next question, right? I'm waiting for your answer in the comment box. So, for do comment your answer. The permanent tracheostomy incision is usually made at which of the following level? Yes, the permanent tracheostomy incision. We have to create the permanent tracheostomy incision. Okay, where we have to create the hole. Option A is telling between the T1 and cricoid cartilage. This is what we call as in the high tracheostomy. If we are opening the trachea between the tracheal ring number 1 and cricoid cartilage. Okay. So remember, bachu, this is our beautiful trachea. Let me describe with the image so it will help to you people. Okay. This is the trachea. And here is the right bronchus. Here is the left bronchus. This is the carina. Okay. So on the trachea, there are C-shaped rings will be there. Okay. So these rings normally, how many in numbers? These are 16 to 20 tracheal ring will be there. This is what you call as the first one, tracheal ring number 1, second, third, and it goes on till the 16, right? So now here is our cricoid cartilage. Above that, thyroid cartilage will be there, right? So if you are creating the opening between the cricoid cartilage and the tracheal ring number first, so here you are creating the opening means you call this one as in the high tracheostomy. What we call this one is in the high tracheostomy. So this high tracheostomy will be performed in case of the laryngeal cancer. CA of the larynx means the cancer of the larynx. So we have to go for the high tracheostomy. The site of creating the high tracheostomy is between the below the cricoid ring and above the first tracheal ring. Okay, so below the cricoid cartilage and above the first tracheal ring. So this is what I actually correct answer. Okay, but the examiner is not asking when we have to create the where we have to create the opening in the laryngeal cancer. He is asking the question Here you have to go for the permanent tracheostomy incision. So we have to go for the permanent tracheostomy incision. Yes, almost all people given the correct answer. Between the second and third tracheal ring, we have to go for the permanent. Okay, so this one is the second tracheal ring and this one is the third tracheal ring. Here I am opening, okay, the trachea. So this is for the permanent. Between the tracheal ring number 2 and 3, so this is the permanent tracheostomy where we have to do in between the tracheal ring number 2 and 3. And examiner asking, and he is nothing mentioning in the question, he is just asking where the tracheostomy hole is created. So that is your preferred answer is the T2, between the T2 and T3. Means it is not between the thoracic vertebra, I am telling. So it's between the tracheal ring number second and the tracheal ring number third. So there we have to go for the routinely and pre-plan the tracheostomy. Means in some cases we have to pre-plan the tracheostomy and we have to go for the opening of the trachea, and for some patient we have to go for the permanent tracheostomy. So that time we have to choose between the T2 and T3, means the thoracic, tracheal ring number second and third. So this is the permanent tracheostomy site. But if the examiner asking which one is used in the emergency, okay, and in the children's. So between the third and fourth tracheal ring, which is preferred in the emergency, which is preferred in the emergency and which is preferred in the children's. Okay, so let me clear all the points. Which is the site of the tracheostomy in the emergency, that is between the third and fourth tracheal ring. Which is the site of the tracheostomy in permanent, means that is the second and third tracheal ring. Which is the best site of opening of the trachea in the children's, that is the third and fourth tracheal ring. And most importantly, which is the where we have to choose for the high tracheostomy, that is between the cricoid and a first tracheal ring. So that is the high tracheostomy. Hope the concept is clear here. Okay, so this is between the tracheal ring number third and fourth, which is for the children's and which is preferred in the emergency. Okay, so let me label. So this one is the cricoid cartilage and this one is the tracheal ring number 1, this one is the tracheal ring number 2, this one is the tracheal ring number 3, and this one is the tracheal ring number 4. Okay, between the 3 and 4 for the emergency and children's, between the 2 and 3 for the routine and permanent, and between the cricoid and the what we can say first tracheal ring, that is for the high tracheostomy in the cancer of the larynx. Okay, so these questions may repeatedly strikes and comes in your exams. So identify this device. Identify this device. I'm waiting for your answers. Identify the device which I have shown in the image. Yes, I'm waiting for your response in the comment box. Bacho, फटाफट do answer for this particular question. Right? Yes, very nice of you all. So this is the trachea dilator. Okay, this is the tracheal dilator. This is the tracheal dilator. So it will be used to dilate the opening during the incision to insert easily the tracheostomy tube. So this is what we call as the tracheal dilator. It's a part of the each tracheostomy set kit. Okay, so where there is a kit of the tracheostomy. Okay, like this one tray will come inside that one. All the equipment set will come like two tracheostomy tube. Okay, and a tracheal dilator and all the solution means chlorhexidine for the cleaning of the inner cannula, normal saline 0.9% for cleaning of the open. Already it's opened means we have to clean with the normal saline. But now it's not open. Just I want to create here means how I have to prepare this part. So this is now called as the surgical site. Okay. So how I have to clear means I have to clean this one with the Previous guidelines says the betadine. Now it says the chlorhexidine solution is used to clear the site of the tracheostomy before creating the tracheostomy. Now after I have created the tracheostomy, now it's a stoma. Okay, here the hole is there. So the stoma or hole is created, cleaned by the normal saline. Okay, so the inner cannula of the what we can say the tracheostomy tube will be cleaned by the hydrogen peroxide. Hope the all question will be clear to you people, right? So this is the tracheal dilator and very important question. Okay, it may directly comes in your exams, right? So here is the next question. What is the classical sign of the subcutaneous emphysema? What is the classical sign of the subcutaneous emphysema? Option D is telling a distinct wheezing sound on exhalation. बच्चों, whenever there is a wheezing sound on the exhalation, means while exhaling the air, means while removing the air from the lungs, there is the a noisy, musy sound is coming. So that is what we call as the wheezing sound. It's classical sign of the asthma. Okay, it's classical sign of the asthma. Okay, so then comes to the option C, increased heart rate and blood pressure. So increased heart rate and blood pressure is not indication of the subcutaneous emphysema. So option B is telling a decreased breath sound on the auscultation. So decreased breath sound on the auscultation, where we have to see. So we have to see this one. If in case of the pneumothorax or the hemothorax or the chylothorax, where the lung is not there, only it's filled with the fluid. Okay, so there we will see a decreased breath sound. So this is also not our answer here. So what is the meaning of the subcutaneous emphysema? First, I will say the just meaning of the emphysema. Emphysema means question air trapping. Okay, what is the emphysema? The emphysema, simple word, it meaning the air trapping, means air is accumulating, air is getting collected in one particular area. So that is what we call as the air trapping or the emphysema. So what happens here? In a two situation, this particular subcutaneous emphysema happens. Means the air is accumulating and trapping in the subcutaneous tissue. Okay, when you will palpate the subcutaneous tissue like this, there will be a sound which is called as the crepitus sound or the crackling sound sensation. It will comes. Okay, right? When you will palpate on the site of the tube, it will produce the crackling sound or the crepitus sound. So that indicates the air trapping. So when we will see the air trapping, okay, so consider this is the face and this is the neck. Okay, here is the stoma. Okay, so around surround of the stoma, around surround of our tracheostomy opening. So here the air will get trapped. Okay, the air will get trapped. Air will get trapping here. Okay, when I will palpate here, when I will palpate around surround of this particular area, so there will be a crepitus sound will come, or we can say the crackling sound. Crepitus sound or the crackling sound will come. So this one, what we call as the subcutaneous emphysema, means beneath the skin, the air is trapping. So that is what we call as the crepitus or the subcutaneous emphysema. Same situations happens here. So here, yes. So consider this is the chest of the patient. We have inserted the chest tube inside for the chest tube drainage. Okay, for the chest tube drainage. So we inserted the chest tube inside. So here, if the patient is of the pneumothorax, means we are draining the air outside, means again it will be air will get collected into the subcutaneous tissue. Okay, so if I palpate this subcutaneous tissue, again here the crepitus or the crackling will come around surround of the site of the tube insertion. Okay, around surround the site of the tube insertion. This is also called as the subcutaneous emphysema. Yes, quickly revise. When the subcutaneous emphysema happens with the importantly with the two things. One is for the site of the tracheostomy. One is for the site of the chest tube insertion. What is the classical picture? So when we will palpate the particular site of the insertion of the tube, where we are feeling the particular very important crackling sensation or the crepitus sensation, so that indicates the subcutaneous emphysema. So this question is very important for you people, right, related to the subcutaneous emphysema. Hope it's clear to everyone, right? So here is the next question. Here is the next question in front of you people. Very, very important question. Most important question. Okay, the scenario based question. Already discussed question. What is the first step to take if tracheostomy tube is becomes accidentally dislodged in a patient? Okay, the patient is there. So in this patient, the tracheostomy tube is there. So it's accidentally came out. The dislodgement of the tracheostomy tube happened. Okay. So what is the next best step we have to do here? Yes. Option A, attempt to reinsert the tube immediately. Option D, oxygen, apply oxygen to the patient through the mouth. बच्चों, the upper area of the patient is obstructed, then only we have created the tracheostomy. Now it's obstructed, we are giving the oxygen through the mouth means no use. Okay, no use. So I am eliminating the option D. So then comes to perform the chest compression. The patient is not collapsed, the pulse is not absent. So the patient is not underwent the cardiac arrest. There is no meaning in the chest compression. So I am eliminating the option C. Then comes to the option B. Call for emergency medical assistance. So before doing this one, we have to establish the airway. First and best attempt we have to do is the reinsert the tube immediately. Okay, this is the reason I told you people we have to keep the two tracheostomy tube at the bedside. One is of the same size, one is of the small size. Okay, so and we have to keep the obturator always be ready at the bedside if the patient accidentally removes the tracheostomy tube. So first we have to reinsert the tracheostomy tube and we have to fix the tracheostomy tube and we have to hyperoxygenate the patient with the amber bag or the mechanical ventilator. Okay, so this is the correct answer. Option A goes to the correct answer for this particular question here. Okay, so hope it's completely clear to everyone. All right, so here is the next question. So what is the meaning of the MBT? What is the meaning of the MBT? That is the massive blood transfusion. What is the meaning of the MBT or the massive blood transfusion? I'm waiting for your answer in the comment box. Fadafat do comment for the question. Yes. While ending the class, I will sum up all the golden points, important points. Okay. So don't you have to worry about that one. Okay. Yes, already we have chanted. Again, it's some very, very important. There is highest chance of asking the 3 to 4 questions. So that is what I have brought the high yield and very high yield concept in front of you people, right? So I have briefly again within a 5 to 10 minutes I will again describe that one. Don't have to worry. Just you have to learn the concept here, learn the facts here. So that is very much helpful to you people, right? Yes, I'm waiting for your answer, and a few of you only given the correct answer. So, what is the meaning of the massive blood transfusion means? Yes, option is telling the transfusion of the more than 4 units of the packed red blood cells in 24 hours. No, bacho. If you are transfusing the more than 4 unit, or if you are transfusing more than 80% of the circulatory volume in 1 hour. So I will say this one is in the massive blood transfusion. Okay, but here it is telling 24 hours. So I'm eliminating the option A. Okay, option A is not correct answer. Then comes to the option B. Option B is the a transfusion of the more than 1 unit of the blood every 30 minutes. No, this is not a massive blood transfusion. Option C, a transfusion of more than 10 units of the whole blood. Okay, so what we are transfusing here, the whole blood, how much we are transfusing, there is the 10 units, okay, in 24 hours. So this is the very, very important, and this is the actually what we have to say, the massive blood transfusion. Okay, very, very important. In the massive blood transfusion, we not only insert the PRBC, okay, we have to insert here the whole blood. The ratio should be, okay, so there is the PRBC, packed red blood cell volume, is to platelet, is to very, very importantly, or first frozen plasma. So it should be 1:1 ratio. Okay. So platelet is to PRBC means here only packed red blood cell we are inserting, platelet we are inserting, and fresh fluorescent plasma we are inserting. So it should be in the ratio of the 1 is to 1 is to 1. So in the massive blood transfusion, we have to maintain this particular ratio. It's very, very important. In the whole blood, all these will be there. Okay. But in the PRBC, only this thing will be there. We are inserting and we are loading only with the PRBC means it may lead to the coagulopathy. Okay. What it will cause? It will cause the coagulopathy because of the lack of the other cells like platelet and fluorescent plasma are lacking means it may lead to the coagulopathy. So always will be the ratio like this in the massive blood transfusion. Remember, we have to go for the whole blood transfusion. Okay, that's the more than 10 units in the 24 hours is the correct answer, or more than 4 units in the 1 hour is the correct answer, or the more than 80% of the circulatory volumes in the 1 hour is the correct answer. Okay, so here the more than 4 units in 24 hours given, so option A is I am eliminating. Then the option D comes to more than 20. No, so I am eliminating the option D also. The correct answer is option C here. Okay, so hope the concept is completely clear to everyone, right? So identify this device. Image based question. Identify this particular device. I'm waiting for your answer. Fatafat do identify this particular device. This is the BT set. This is the BT set, means the blood transfusion set. Sir, it is looking like a IV fluid set, sir. How we have to different, sir? It seems like IV fluid set, but here is the filter will be there. Inside the BT set, here is the filter will be there. Inside of the barrel, there is filter will be present. So very, very important. How we have to differentiate means by looking at the filter, we have to differentiate it. Okay. Hope it's clearly visible in the particular image what I am showing here. If it's not clearly visible, just after the finishing the class, go for the Google and type as a blood transfusion set and focus just between the compare between the IV fluid set and BT set. Okay, in the IV fluid set there is no filter, but in the BT set the filter will be there. So it's very, very important. Okay, so the question will comes here, sir, when we have to change the BT set? When we have to change means every 4th hour. Okay, you can use the BT set only for the 4th hour. Okay, consider if you are doing the 2 PRBC transfusion. Okay, so one bag and another bag. Here you have connected this BT set and connected to the patient. So now this one is empty. Okay, whether I can use the same to second bag? No. So again to the second bag, go with the fresh and new BT set. Okay, because one BT set transfusion, one blood bag transfusion be done in the less than 4 hours. Okay, so never ever go more than 4 hours for a transfusing one PRBC bag. Okay, if you are going more than 4 hours, means it will cause the bacterial contamination and bacterial infection. So that is very, very dangerous and very, very harmful to patient. Okay, so that is the reason BT set, if you are using to the next month, so don't use the same one, use the new one. Okay, use the new one, and one BT set will be used for the only for the 4 hours. Okay, so consider this is the blood bag and this is the blood transfusion set. So here we have to discard the blood bag. Yes, blood bag will go into the yellow biomedical waste management. But blood set, this BT set, we have this one. This one we have to discard in the red. Okay, so very, very important. Understand the minor difference and minor important golden point. Okay, so that will be helpful for your upcoming exams. Hope the concept is clear on this BT set. Okay, yes. So here is the next question. Who is considered as the universal donor for a red blood cells transfusion? Option A, O positive. Option B, O negative. Option C, AB positive, and option D, A negative. Who is considered as the universal donor? Universal donor. Yes. Look at this chart, bachcho. Here, the O negative, he is giving the blood. He is giving the blood to everyone. Means he can donate the blood to the everyone. So the O negative is considered as a universal donor. He is considered as the universal donor. And focus the same here. AB positive. Okay, AB positive is the blood who is receiving the blood from the everyone. Okay, so whomever it may be, he is receiving the blood from the everyone. So AB negative is called as AB positive is called as the universal recipient. Okay, so very important. Which blood group is called as the universal donor? That is the O negative, and AB positive is called as the universal recipient. Okay, so let's comes to our option here. Yes, the question is on the universal donor. Okay, so who is considered as the universal donor? That is our O negative is considered as the universal donor. Okay, then universal recipient is the AB positive is the universal recipient. And the one more example come, the patient will came in the emergency department, okay, with massive blood loss, okay, and blood grouping of the patient is not known. Okay, so if we don't know what is the blood group of the patient, then we have to choose for the one single best blood group to transfuse. So in the emergency, the patient blood group is don't know means go for the O negative blood transfusion, because we can give this blood to the everyone. So that is what we call as the universal donor's blood. Okay, very important, very important. And the AB positive will receive the blood from everyone, so we call them as the universal recipient. So very important. All people have to understand and give the best shot of the answer. Okay. So the next question is, what is the maximum typical shelf life of the packed RBC? Okay. So the question is asking the maximum shelf life of the PRBC, where you have to store in the standard condition. Okay. So very important. And the golden table chanting I will do here after immediately after this question. And I am waiting for your answer in the comment box. So please for do comment. Yes, better. Class will go for the long duration because syllabus is vast, and at least I want to cover the very important topics. Right. So what is the maximum typical shelf life of the PRBC when we will store in the standard condition? Okay. So option A 24 hours, option B 21 days, option C 42 days, option D 60 days. Sir, we have studied the range of the 21 to 42 days, sir. Now, what is the best correct answer we have to give, sir? Sir, what they have asked exams in the question, sir? They have asked the maximum, sir. So give the answer as the maximum, sir. It's very simple, sir. Okay. So there is no need of confusion. Okay. So 42 days is the maximum we have to store for the PRBC. Oh yes, everyone have given the correct answer. Who have chosen the other options, so please do correct your answer. So it's in 42 days we have to store a PRBC when we will store it in the maximum particular temperature. Okay. So yes, I hope it's clear. It's the shelf life of the RBC in the blood bag. But if the examiner asking the cell only, just he is asking the what is the lifespan of the RBC? Yes. What is the lifespan of the RBC? Yes. Do comment everyone in the comment box at the end of this class. Right. Yes. Here is the next question. What is the lifespan of the RBC? Everyone should comment that one. And if you are a true aspirant, you have to comment what is the lifespan of the platelet also. Right. So both comment in the comment box at the end of the class. Okay. So here is the very important golden table for the chanting. Okay. Whole blood. Okay. Whole blood means here we are having the RBC, and we are having the platelet also, and we are having the plasma also. That is the fresh frozen plasma also, it will be there inside. Okay. So everything will be there. So that is what we call as the whole blood. So when we have to transfuse the whole blood, when there is in the massive blood loss, means blood loss means only not only RBC will get reduced, not only platelet will reduce, not only plasma will reduce, all thing will be get reduced in the massive blood loss. Okay. So RBC also decreased, platelet also decreased, plasma also decreased. So there we are giving the whole blood. Okay. So in the massive blood loss, so how we have to store the whole blood means we have to store it between the 1 to 6 degree Celsius, and in the refrigerator we have to store this one. Okay. So the shelf life of the our whole blood is the 21 to the 35 days is the shelf life of the whole blood. So then comes to the packed RBC, or we can say red blood cell, or the packed red blood cell. So here we are having the only RBC. Okay, no platelet will be there and no fresh frozen plasma will be there. Okay, just we are having the a concentrated RBC. So this PRBC transfusion, so this PRBC transfusion we can do in a case of the anemia. Okay, anemia, what happens? Only RBC will decreases. Okay, the platelet and remaining rest plasma, everything will be normal. Just we have to transfuse the PRBC in case of the severe anemia if hemoglobin is less than 7 gram per deciliter. So hemoglobin is less than 7 gram per deciliter. Then you will go for the PRBC transfusion. Okay, so PRBC will be transfused in case of the anemia, and whole blood will be given in case of the blood loss. Okay, so then again the same, we have to store the PRBC at the 1 to 6 degree temperature, and again in the refrigerator we have to store this one till the 41 days, and range is coming from the 21 days to the 41 days, but the best answer is the 41 days is the correct and best answer. Okay, when you will come for the cryoprecipitate, it will be stored in the minus 18 degrees Celsius. Okay, and we can store the cryoprecipitate for the duration of the 1 year, and we have to keep it in the freezer. Okay, so we have to keep the cryoprecipitate in the freezer. Same, the fresh frozen plasma here is the fresh frozen plasma. We have to store this fresh frozen plasma in the minus 18 degrees Celsius for the duration of 1 year we can store, and again fresh frozen plasma will be stored in the freezer. But never ever keep the platelet in the freezer. The platelet should be stored in the room temperature. Okay, so where we have to store the platelet, we have to store the platelet in the room temperature. Okay, so room temperature is 20 to 24 degrees Celsius is the room temperature, and we can store this one for the maximum only for the 5 days. Okay, so yes, the storage area of the platelet will be the incubator we can use of the 20 to 24 degrees Celsius, or we can say the room temperature we can store the our platelet. Remember the golden point, platelet will be stored only for the 5 days, and platelet will never ever be stored in the refrigerator and freezer. Keep the platelet in the room temperature only. Then comes to the RBC, the golden point, we can store for the 21 to 41 days. Our best method to store is the refrigerator we have to keep, and cryoprecipitate and plasma, fresh frozen plasma, we can store this one up to the 1 year. Up to the 1 year, the temperature of the storing this cryoprecipitate and fresh frozen plasma is the minus 18 degrees Celsius. Okay, we have to keep it in the freezer. Very very important points. All the people have to know, understand, and give the best answer in the particular exams. Okay, when we will use this cryoprecipitate and the fresh frozen plasma, yes, in case of the hemophilia. Okay, so in case of the patient comes with the hemophilia, we can use, and platelet transfusion in case of the dengue. Okay, in case of the dengue hemorrhage. Okay, and very very importantly, we can use in case of the thrombocytopenia also. The platelet transfusion is very very important. Hope the concept is clear on the everything, blood components and its use and its storage, and the highly important points on the every components of the blood. Okay, so here is the next question, very very important question again. It's a very very important question again. So this question directly may strikes in your exams with the same option. Okay, yes, what is the recommended maximum duration for completing a blood transfusion for 1 unit of the PRBC? Yes, you have received the 1 unit of the PRBC from the blood bank. So what is the from the blood bank you have received the 1 unit of the PRBC. So what is the recommended maximum duration? We have to keep it at the patient bedside or at the warmer, and for the completion of the blood transfusion. Okay, sorry, it's not like this. What is the recommended maximum duration to complete the BT? Okay, to complete the transfusion, what is the duration? Yes, so we have started the blood transfusion, the BT have been started, right? So to complete this BT, how much duration we have used? So already I have discussed this one. The maximum we can transfuse for the 4 hours. Okay, don't go more than 4 hours. If you are going more than 4 hours, means increased chance of bacterial contamination. Okay, very important. And we have to start the transfusion. We have to start the transfusion within 30 minutes of receiving the blood from the blood bank. Okay, so you have received the blood component from the blood bank, right? So within 30 minutes you have to start the transfusion. If you are not starting the transfusion within 30 minutes, means send back the blood to the blood bank, repeat. Okay, so because the one single drop of the blood matters, and you know how difficult to get the blood. Okay, it's not like this you have loaded the subtraction injection and you have kept the for the 2 hours, and if you are not using, you are discarding the injection. But the blood is not like this. You have received from the blood bank, means you have to use that one, and you have to start the transfusion within 30 minutes. If you are not starting the infusion within 30 minutes, means send back the blood to the blood bank. Okay, so that is the most important point. Okay, so and the examiner asking how much duration we have to take for completion of the one PRBC unit means we have to complete it in the within 4 hours. Okay, within the 4 hours. Here is the golden table for the duration of the transfusion. Very important. As I told, the whole blood and PRBC we have to start within 30 minutes. Okay, start of the transfusion should be within 30 minutes of the taking from the particular blood bank, and we have to complete it less than 4 hours. Okay, so if it's still remaining after 4 hours, means discard the unit if the period exceeds. Okay, so the BT is not completed within the 4 units, means still 20 ml blood, 30 ml blood is there, means discard that one. Don't use that one because it increases the risk of the bacterial contamination. Very important. Okay, remember the golden points. Whenever you will receive the blood from the blood bank, so come start the transfusion within 30 minutes, and if you are not using, then send it back to the blood bank, and the complete blood should be transfused within 4 hours. If you are not completing within 4 hours, send this particular so discard the particular blood. Okay, if it exceeding the 4 hours. Okay, if it's crossing more than 4 hours, don't use that blood. Okay, so that is the very important point all you people have to understand here. Okay, so here is the next question. Next very important point, there is the platelet concentration. Okay, so here also we have to start the transfusion immediately after receiving from the blood bank, and should be completed within 30 minutes. Okay, so no need for the going till the 4 hours. Here we have to started the transfusion within the 30 minutes. We have to complete the transfusion. Same for the first frozen plasma, as soon as possible we have to start and complete it within the 30 minutes. Cryoprecipitate completed within the 30 minutes. Okay, so very importantly, so maximum time duration for waiting the whole blood and PRBC is for the 30 minutes. After that, we have to send it back to the blood bank if you are not using, right? So many times I am repeating this particular concept because it's a nursing responsibility, and the question will come from here. Okay, the question will come from here. So I am mentioning it's a very important table. Very important table. Okay, so hope the concept is clear on the first particular thing what I have explained in the last particular slide. Okay, so here is the next and very important question. Yes, that is the which of the following is the most common complication of the blood transfusion? Question is asking the most common complication of the blood transfusion. So what is the most common complication of the blood transfusion when you will start the blood transfusion? Okay, you have started the blood transfusion, means which one is the most common complication? Yes, so I'm waiting for your answers in the comment box. So please do fatafat mention your answer in the comment box, right? Fatafat bachcho, I'm waiting for your answers. Option A is telling hemolytic transfusion reaction. Option A is telling hemolytic transfusion reaction. Option B is telling febrile non-hemolytic transfusion reaction. So in short, we can say this one as in the FNHTR. Okay, so examiner just can give the FNHTR. So don't have to fear here. Okay, it meaning febrile non-hemolytic transfusion reaction. Okay, so this is the most common transfusion reaction. When you have started the blood transfusion, the patient will get the fever, but there is no any hemolysis. So this is the most common type of the transfusion reaction. It's a very important. All people have to know and understand and give the best shot in the exam. Okay. So all anaphylactic reactions also happens. Iron overload also happens, and hemolytic transfusion reaction also happens. But the most common one is the option B is the most common one. Okay. So hope it's clear to everyone. So what is the treatment of the febrile non-hemolytic transfusion reaction? Yes. So start the PCM injection. PCM we have to start. Okay. So that is the very important. PCM here means the paracetamol. We have to start. There is the 1 gram IV intravenous paracetamol 1 gram IV have to start if the patient is getting the febrile non-hemolytic transfusion reaction. Hope it's completely clear to you people, right? So here is the next question. The next question is, which of the following is a sign of the anaphylactic reaction during a blood transfusion? During the blood transfusion, so which of the following is a sign of the anaphylactic reaction? So I'm waiting for your answer. It's a very important question again. Option A low back pain and dark urine. Bachcho, whenever there is a low back pain and dark urine, which indicates the blood is damaging, means it is a clear and classical sign of the hemolysis during the blood transfusion. Means so the blood is damaging during the transfusion because of the any antigen antibody reactions. So that is the patient is complaining of the sudden low back pain and the patient is having the dark color urine. So that is indicating the blood is damaged during the transfusion. So it's not a classical picture of the anaphylactic reaction. Okay. So the patient is having the hypertension, rapid chills and fever. So the rapid chills and fever along with the hypertension, it will come means it may indicate the bacterial infections because of the contaminated blood transfusion. Okay, so then option B indicates the fever and chills, just mild fever is there and just the chills is there. So which indicates the yes, a febrile non-hemolytic transfusion reaction. It indicates the FNHTR, right? So option C is the breathing difficulty, hypotension and swelling of the throat, which clearly indicates the patient is going into the allergic reaction of the blood transfusion, or we can say the patient is going into the anaphylactic reactions of the blood transfusion. How, sir? How it happens? Means the anaphylactic reactions happens because of the allergy. So when there is an allergy, so allergic means the histamine will increases. What increases? Histamine will increases. This histamine, it will stimulate the H2 receptors on the trachea, and there is then the trachea and bronchospasm will be there. Okay, trachea and bronchospasm will be there. So trachea and bronchospasm, which makes the patient to for the difficulty in breathing, right? And this histamine is also having the effect of the vasodilation. Okay, it having the effect of the vasodilation. So if the patient is having the vasodilation, means the blood will pool in the periphery only. Okay, so that will lead to the blood pressure will decreases. So hypotension will be there, a spasm of the respiratory tract, so breathing difficulty will be there, and because of the allergic reaction, the BP is decreasing and histamine is doing the vasodilation, means a capillary permeability will increases. Means the capillary permeability increases means the fluid will leak from the capillaries. So there is swelling around the particular throat. So that may call as the laryngeal edema also may happens. Okay. So this is the classical sign of the anaphylactic reaction during the blood transfusion. And another options also I have told you people. Remember very important point. Patient is complaining the low back pain and the dark urine during the transfusion, means that indicating the hemolysis along with that the anaphylactic reactions, the breathing difficulty, hypotension and the swelling over the throat, that indicating the severe allergic reactions or the anaphylactic reactions. Okay, so during the blood transfusion, most important. Okay, the most important. So then comes to the next very important scenario based question. This question will cover the entire doubts clarification, right, on the complications of the BT. So if you are studying this one particular question, you may solve the 6 to 7 question which will comes on this particular topic. Okay, so it's very simple and important. So The question is like this: a 65-year-old woman, she is having the history of the hypertension, means her blood pressure is more and the vessels are congested, and she is also having the history of the heart is getting failed with a reduced ejection fraction. What is the ejection fraction? This is the heart. In this heart, there is the blood will be there. When the heart will pump, means the blood will eject out. The fraction of the blood will eject out. So how we have to say the fraction of the blood? The percentage of the blood is ejaculated out during the heart contractions. This is what we call the ejection fraction. So how much blood will eject out? Once the heart is get contract, the 70% of the blood will comes out. Okay, so normal ejection fraction is the more than 70%. Okay, so the range will start with the 60 to 80% is the normal ejaculation fraction, right? So here the reduced ejection fraction means the heart is failed, means the ejection fraction when it goes below the 45 percentage, we say the heart is getting failed, means heart is unable to pump, means the ejection fraction is less than 45, then only we call that one as the reduced ejection fraction and the heart failure. Okay, means the heart is not heart is pumping and the blood is not going outside, means again the blood vessels are congested here. So already patient is having the hypertension and the blood vessels are congested. The patient is having the heart failure with reduced ejection fraction, means the blood vessels are already filled with the blood, and patient is receiving the blood transfusion. Why? The patient is receiving the blood transfusion due to the blood loss following the surgery. Patient had the surgery, then that time the blood is get lost. So after the first 1 unit of the blood transfusion, so we have done the 1 unit of the blood transfusion. Now the patient is being experiencing the difficulty in the breathing. The breathing difficulty is there and raised blood pressure. The blood pressure is increasing and increased heart rate. The heart rate is increasing. So she is also showing the sign of the pulmonary edema. Means the blood is congested over the lungs also. So what is the most likely cause of these symptoms? Option A hemolytic transfusion reaction. As I told, in the hemolytic transfusion reaction, the classical sign lower back pain plus dark color urine. Okay, whether anywhere mentioned in the question? No, sir. Eliminate this one, sir. Yes. So then comes to the anaphylactic reaction. But while telling the anaphylactic reaction, I told yes, there is difficulty in the breathing is there, but blood pressure is not rises. There the hypotension happens, but here is the raised blood pressure is there. So I'm eliminating the option B also. Then comes to the option C. A transfusion associated circulatory overload, that is the TACO. So this is our correct answer. Okay. So what is the TACO? TACO is the a transfusion associated circulatory overload is our answer. Okay. This is the also a complication of the our what we can say blood transfusion when we will go for the multiple blood transfusion, especially it happens in the massive blood transfusion where transfusion the more than 80% of the circulatory volume in 1 hour or more than 10 units of the bloods in the 24 hours. That time there is highest chance of the TACO, that is the transfusion associated circulatory overload. So this is the our correct answer here. Okay, option C goes to the correct answer here. Okay, it's the very important point to you people. Okay, in order to avoid the TACO, so we have to administer the blood in the controlled manner and don't administer the overflow in the hypertension heart failure case, and that causes the highest risk of the TACO. Okay, hope the concept is clear to everyone. Okay, so that is the very important concept. So that makes your clarification and very important all features of the TACO we have discussed. Okay, remember during the BT the patient is having the hypertension, the patient is having the difficulty breathing, and the patient is having the crackles. During transfusion, crackles are there, difficulty breathing is there, and blood transfusion, because of the blood transfusion, blood pressure is high. So that indicating the circulation is overloaded. Okay, so that is what we call as the circulatory overload that is associated with the transfusion. Okay, hope the concept is clear to everyone. And here is the next question. Which of the following is commonly used to treat iron overload in a patient receiving a frequent blood transfusion. A patient is receiving the frequent blood transfusion. Okay, means a patient may be a case of the thalassemia. A patient may be a case of the sickle cell anemia. Okay, these are the hemolytic anemias. Here we have to go for the repeated blood transfusion. Okay, repeated blood transfusion is required here. So the patient is requiring the frequent blood transfusion or the repeated blood transfusion. Here the RBC we are repeatedly giving to the patient. When this RBC breaks, so it is made up of the hemoglobin, and in the hemoglobin the iron is there. Okay, so we are giving the RBC means we are giving the hemoglobin. We are giving the hemoglobin means we are giving the iron also. So because of the over transfusion of the blood, so there is chance of the iron overload will be there. So in order to prevent this iron overload, which one we have to use in the treatment of the iron overload? So there is the desferrioxamine, or we can say deferoxamine also. We can call this one. We can call this one as in the deferoxamine. Okay, very important, and we can say that one as the desferoxamine also. So this is also called as the antidote of the iron toxicity, or we can say whenever there is the iron overload in the blood transfusion, repeated blood transfusion, then we have to go for the desferoxamine as the treatment. Okay, it's very important for everything. Yes, here is the next question. A patient is receiving a blood transfusion who develops the symptoms such as the numbness and tingling around the mouth. Very important. I will clarify this one again. Then the muscles are cramping. The muscles are cramping means the spasticity of the muscles happening and increased deep tendon reflex. The deep tendon reflex are increased here. So what is the most likely cause of these symptoms? The patient is having the blood transfusion. He is having the numbness of and tingling around the mouth. Means what is the actual answer here? So I'm waiting for your comment and answer in our comment box. Okay, yes, please do comment your answer. A patient is receiving the BT and he is experiencing these symptoms. Yes, this is because of the hypocalcemia. Yes, the blood calcium is decreased. Sir, why it happening? Means in the blood transfusion we are using one component that is called as a citrate. In the blood bag we are using the citrate. So this citrate is an anticoagulant. Means as I told previously, only the flowing blood, the circulating blood will be in the thin format. When the blood will be stored in one place, it will get clot. Okay. So in order to avoid the clotting, we have to add the anticoagulant to the blood bag. Okay. Which anticoagulant we have to add to the blood bag? That is the citrate is the anticoagulant we have to add to the blood bag. So this citrate, what happens? It will bind with the calcium and it will bind with the magnesium. And if we have transfused the blood more means it will citrate binds with the calcium and the blood calcium level will decreases, and the citrate bind with the magnesium, blood magnesium level also will decreases. In the blood transfusion we have to expect the hypocalcemia and hypomagnesemia. Okay, very important. And because of the hypomagnesemia, our deep tendon reflex is increased here. Whenever there is in the increased deep tendon reflex means yes, our magnesium level is decreased. Okay, whenever the magnesium level increased means the deep tendon reflex will get lost, or absent of the deep tendon reflex means the magnesium is overloaded. Okay, magnesium is decreased means the hyperacute reflexes will be there. Okay, so and along with the same the calcium will decreases means the perioral numbness. So this is the oral cavity, around the oral cavity, the perioral numbness is the earliest sign of the hypocalcemia. Okay, what it is in the early sign of the hypocalcemia, that is the tingling and a perioral numbness and muscle cramping. Because of the hypocalcemia the muscles are cramping means we call that one as in the tetany. Okay, what is tetany? The muscle cramps because of the hypocalcemia. So here it's clearly indicating the citrate is binding to the calcium and calcium is low, so it indicating the hypocalcemia. So that is the reason. So when giving the massive blood transfusion, we have to give this massive blood transfusion with the injection calcium gluconate. Sir, how much? That is the 10 mg in 100 ml NS for 30 minutes. Okay. So never ever administer the calcium directly in the IV. So we have to calcium need to dilute with 100 ml NS and we have to infuse it with for the duration of the 30 minutes. Okay. So if you are giving the calcium and potassium direct IV means the patient will go into the cardiac arrest. Okay. Remember. Okay. Don't give the calcium and magnesium direct IV. The calcium given that is the 10 mg in 100 ml NS for the 30 minutes. It's very important. Okay. So it will be comes in your exams. And the same question in the neonatal jaundice, we will go for the exchange blood transfusion. Means entire blood from the neonate we will remove and entire blood we will replace in the neonatal blood exchange blood transfusion. There also there is highest chance of the hypocalcemia. So in between the exchange blood transfusion, we will use the injection calcium gluconate. So we have to use here. Okay. Just a second, please. Yes. A second, please. Right. So that is the very important thing all you people have to understand and remember for this one. Okay. So I hope that question is clear to everyone. And here is the next question. So patient is receiving the IV chemotherapy. The patient is receiving the IV chemotherapy, experiencing the severe pain and tissue damage. There is patient is receiving the chemotherapy, one cleave got, and he is getting the severe pain and tissue damage at the site of the intravenous infusion. With a blisters are there and slugging of the skin is there. So which complication is most likely is this? Option A, infiltration. Option B, a phlebitis. Option C, extravasation. Option D, hematoma. So in hematoma, only it will become red or the dark. Okay, there is no severe pain, there is no tissue damage. Okay, there is only the capillaries will get ruptures and the capillary blood will accumulate at the one side. We call that one as in the hematoma. Okay, so this is our not our answer. Then comes to the extravasation. What happens here? So this is our vessels, and we are given that chemotherapy means a dangerous vesicant drug. Okay, so these are the vesicant drug. If this goes out of the vein, if it goes out of the vein, it will cause the necrosis of that particular area. So that is what we call as the vesicant medicine. Means a irritant medicines also we can say. Okay, if this goes blood particular fluid goes out of the veins, so that is what we call as the extravasation. Means it's gone out of the extra means out of the vessels. Okay, so here these particular chemotherapeutic drugs it will it will cause the severe muscle damage. Because of the muscle damage there is excessive severe pain will be there, and along with that the tissue will get damaged at the site of the IV infusion. So it clearly indicating the extravasation. Sir, how we have to differentiate between the infiltration and phlebitis? Infiltration is the yes leaking of the fluid, at the site of the infusion. So same, but infiltration it indicates it's not a leak of the extravasating drugs. It may be a normal saline, it may be a whatever it may be. Okay, so that like ringer lactate, IV fluid, it is a leaking in the subcutaneous tissue. That is what we call as the infiltration. Okay, so here also pain is there, redness is there, and yes, coolness will be there. Okay, at the site of the swelling and pain, here we are getting the coolness. So that is indicating the infiltration. Okay, when it comes to the phlebitis, the pain will be there, redness will be there, swelling will be there, plus warmness will be there, because it is on the phlebitis. It's an infection inflammation means it will be warm. Okay, so here it's an Fluid leak means the under the subcutaneous tissue fluid is there. When I will touch that one, it will looks like a pool. Okay, in the question, a pain, redness, swelling plus coolness is there. So your answer is infiltration. In the question, pain, redness, swelling, and warmness is there. Your answer is the phlebitis. That is the infection and inflammation of the vein. And the site of the IV infusion, there is the severe pain, tissue damage, and a blistering will be there. So that is your extravasation. Very very important. So this is how we have to differentiate and give the best answer for your upcoming questions in the exams, right? So hope the all concept is clear to you people here, right? Every concept is clear to you people. And here is a beautiful advertisement. So all are preparing for the RRB nursing superintendent exams, RRB nursing superintendent exams, we are having a very important and very beautiful, completely planned syllabus in a test series. So that is the RRB Vande Bharat test series for your nursing superintendent exam, which is available in our Master Nursing Classes app. So you have to download the Master Nursing Classes app from the Google Play Store. Okay, the link is given in the description box and in the comment box. So if you want, you can download the Master Nursing Classes app from here. Okay, and still, if you are having any doubts in your mind, you want to clear all the doubts. So we are having a beautiful WhatsApp group, Telegram groups, where the 3,000, 4,000 plus students, they are engaging in the solving the questions which is asked by the expert nursing officers continuously. So if you want to be a part of that one, yes, do join our WhatsApp group, Telegram group. I have given the link in the description and comment box. If you want, you can join there. Okay, so I think it's clear to everyone, right? So if you are preferring just for the Norcet 8, so you are also having a beautiful plan. That is the Norcet 8 test series. If you are preparing for the both, means here we are having the a combo offer. That is the sure selection test series. Here you are getting the both Norcet test series, RRB test series, everything. Okay, it's very important questions, updated questions we have installed in the test series. If you want, you can choose that one. Okay, so that is very much helpful for you people, right? So here is the next question on the amla cream. Okay, so what is the amla cream? What is the amla cream? Before going to the exam, main questions we will discuss that one. Yes, can we read the question first? Yes, we'll read the question. We will solve the answers. Then we'll go for the description of the amla cream. Okay, how long should amla cream be left on the skin before it becomes effective? Before it becomes effective, how long we have to keep at the contact with the skin? Yes, option A 5 to 10 minutes, option B 30 to 60 minutes, option C 2 hours, option D 10 to 15 minutes. What is your answer? First, let me tell you what is the amla cream. Amla cream is the eutectic mixture of local anesthesia. Okay, so here the two local anesthesia, one is lignocaine and one is prilocaine. Okay, lignocaine and prilocaine both are mixed, and there is a cream we have prepared. So that cream we have to apply over the site of the IV cannulation or 30 minutes to 60 minutes before the IV cannulation. Okay, so before IV cannulation we have to apply this cream here. We have to give a gap of the 30 to 60 minutes, means till the 30 to 60 minutes the area become completely numbness. Okay, then if you are pricking also, patient will not get the pain. So amla cream is used for the painless IV cannulation. Okay, for the painless IV cannulation, the best cream we are using is the amla cream. So the question came on this one in the last previous exam. Okay, so the maximum we have to keep a skin and a cream contact is the 60 minutes and minimum is the 30 minutes. If the examiner asking at least contact between the skin and cream is the 30 minutes we have to keep, and maximum it's in 60 minutes. The range is belongs to the 30 to 60 minute contact between will be there between the amla cream and the skin. So then it will make the skin completely numb. Okay, then we can go for the IV cannulation. So it is used for the painless IV cannulation. Painless IV cannulation. It's very important, right? So it's a very important question. Again, right? Mark it out. Okay, so hope the amla cream is clear to everyone. And in the next session, we will discuss the most important question again. Okay, so on the pressure store. Okay, so again, where I will be delivering the most important questions to you people. Okay, that is much necessary for your upcoming exams. So stay connected, stay motivated, and keep preparing. And if you want to be a part of our master nursing classes, do download the app and practice the best test series that will definitely give you a result, because it's based on our experience of the writing all the Norcet exam. We know what the examiner is playing with us. Okay, so accordingly that we have prepared the test series. So if you want to be a part of that one, I have given the link in the description box. Download the master nursing classes app. And if anyone is new to the YouTube family, so please do subscribe to the channel. And if you have any doubts, so do mention in the comment box, so I will clarify it in the next session, right? So yes, okay, we will wind up the today's class here. Yes, thank you so much. Thank you to everyone for the joining the session. We will wind up the today's class. We'll meet in the next class. तब तक के लिए जय हिंद, जय भारत. क्लास को शेयर करना ना भूले. Please everyone share the class and keep it in your WhatsApp status, so that will help us to grow up the master nursing classes, which is giving you a best content. Okay, right? We will wind up the today's class. We will meet in the next class with the beautiful questions again. Stay connected.